Good morning, everybody. Good morning. I wanted to welcome you to the symposium. Gosh, it's so hard to get up so early when, we have our kids at home, and this is our time to relax, right? And what are we doing? We're getting up just like we would with the kids, right? Anyhow, welcome to the Satellite Symposium presentation entitled Practical Navigation of a Challenging Landscape, Keeping Current on Multiple Myeloma Treatments. A special welcome to our webcast. We have a lot of people at home, signed up for our webcast, and we want to thank you as well for getting up so early and spending your morning with us. In order to continue providing you with quality advanced training, we need to account for everybody in attendance, so please don't forget to sign in, and the evaluation forms are critical at the end. This activity is certified for nurses, so please refer to your handout materials for specific credit designation. Imer is conducting research during this activity too, and your responses will be recorded. As you'll see at the beginning, we'll have some practice pattern questions. So we would like you to locate your keypads because we're going to be asking you to key in your responses. The pre- and post-assessment questions will be presented before and after each agenda question. So we'll read a pre-assessment and we'll find out the answers later. We want to see how we've been able to increase your knowledge. A program evaluation has been provided for your program folder. Please complete the evaluation and sign it, don't forget to sign it, and deliver it to the Imer staff at the conclusion of the program. In terms of clinical tools and resources, Imer has provided clinical tools and resources specific to the assessment and management of myeloma on your USB drive, and that's that little thumb drive. These are also posted on the web page associated with this activity at www.imeronline.com. For additional listings of resources for the newly diagnosed patient, clinical tools regarding staging, prognosis, assessment, and management, please visit imeronline.com. And finally, please turn off your cell phones or put them to vibrate during this presentation. My name is Beth Feynman. I'm the chairperson for this activity. I'm joined by my esteemed colleagues, Pat Killingsworth, who today is one of my colleagues. He's going to be sharing a patient perspective, and Paige Bertolotti, RN, and we're going to be sharing an overview of myeloma. This is our disclaimer. There we'll be discussing off-label uses. That means they're not approved by the Food and Drug Administration, but the information is so important we wanted to share them with you today. These are our disclosures of conflicts of interest, and they're also located in your handouts. And don't forget, it's extremely important that you fill out and sign your evaluation forms. Here are listed our learning objectives, and we're hoping that on completion of this activity, you'll be able to identify the risk factors, staging, prognosis, and cytogenetics of myeloma. Discuss the recent research. You might only have 1 or 2 patients with myeloma, but to understand what kind of therapies that they should be receiving is critically important. Identify new combination therapies, maintenance therapy, the role and timing of stem cell transplant, and then outline an evidence-based nursing care plan for your myeloma patients. As nurses, we want to know the plan of care and share it with our patients so we can mutually meet our goals of keeping them in remission and keeping them alive longer. And then finally, describe potential side effects from the myeloma treatment and the recommendations for management. This is our activity agenda, and we're going to start with some demographic questions. This is to get your fingers moving in the morning. Which describes your primary practice setting? Inpatient, outpatient, academic, inpatient, outpatient, or private physician practice? And I know I always fit into like 5 of these categories, so just pick one. Fantastic. So community outpatient and community inpatient. Which best describes your primary nursing role? And we all wear a lot of hats too, but try to do your best to identify if you're an academic educator, case manager, nurse specialist, clinical trials nurse, or any one of the others listed. Oh, wonderful. Staff nurse, nurse clinicians. This is wonderful. In a typical month, how many patients with multiple myeloma do you see? 1 to 5, 6 to 10, 11 to 15, more than that, or I don't see patients with myeloma. This is great. So a lot of what we're going to be sharing with you today is going to help increase your knowledge of looking for those patients with myeloma and helping to know what goes into the diagnosis. So this is a practice pattern question. So this is one of those as we had designed to help try to evaluate if you've learned anything today. Your patient is receiving IV bortezomib, and this is the standard dose, 1.3 milligrams per meter squared, days 1, 4, 8, and 11, and dexamethasone the days of and after treatment. He has achieved a partial response, which means the protein went down 50%, and he developed tingling peripheral neuropathy symptoms when he was receiving the IV after the 3rd cycle. What is the best course of action? Continue the standard dose of IV bortezomib to see if the pain gets better, prescribe oxycodone and OxyContin to treat the pain, switch to weekly bortezomib at the same dose and schedule, continue standard dose of bortezomib but switch to subcutaneous, or stop bortezomib and switch to lenalidomide and melphalan. And you're thinking, what do I know? And that's why you're here this morning. Wow, so we had some really good responses. Switch to weekly and continue. So what is the level of your knowledge of carfilzomib for the treatment of multiple myeloma? No knowledge, somewhat knowledgeable, knowledgeable, or very knowledgeable? This is one of our newer drugs, so it's okay if you don't have a lot of knowledge. It's great. And this is what it's been kind of running across the board. What is your knowledge of elotuzumab for the treatment of multiple myeloma? Again, one of our newer drugs. Do you have any knowledge of it is what we're trying to look for. Okay, very good. And what about panobinostat for the treatment of myeloma? Fantastic. And vorinostat, I believe this is the last one of our newer drugs that we're asking about your level of knowledge. Okay. Do you provide survivorship care plans for your patients? Yes, no, or uncertain? And this can be myeloma patients or all patients, actually. Okay. I would like to introduce Paige Bertolotti, who's going to describe the diagnosing of multiple myeloma for you this morning. Thank you so much. I'll see you in a bit.
Good morning, everyone. Thanks so much for being here. This section is going to review how to diagnose multiple myeloma. What is the diagnostic criteria? We'll start with a pre-assessment question for multiple myeloma. Is it greater than 3 grams per deciliter of M protein in the serum or urine? Greater than 10% clonal plasma cells in the bone marrow? No end organ damage? At least one of the following: hypercalcemia, renal insufficiency, anemia, or bone disease, 1, 2, 4, or all of the above. And we'll go over that result at the end. Multiple myeloma is a malignant proliferation of a single clone of plasma cells that arise from B cells in the bone marrow. It causes extensive skeletal destruction, which results in bone pain, fractures, spinal cord compression, and hypercalcemia. There is end organ damage that occurs, and it's best remembered by the mnemonic CRAB, C-R-A-B, for hypercalcemia, renal insufficiency, anemia, as well as bone impairment. On presentation, most patients, 97% of patients with multiple myeloma, have the presence of an M protein either in the serum or the urine. They can also present with hyperviscosity. With the excessive M protein that's in the blood, it literally moves around like sludge. That's most common in patients that have an IgA type of myeloma. 96% of patients have the presence of plasma cells in the bone marrow, and it's greater than 10% plasma cells. Skeletal involvement occurs in 80% of the patients, and most of the patients present, of course, with pain. They lose height as compression fractures occur, lytic lesions with bone destruction that's a result of the plasma cells, pathologic fractures. There's many patients that simply reach across to make the bed and the rib will snap. Osteoporosis, hypercalcemia, and about 40 to 73% of the patients are anemic as the plasma cells interfere with the ability of the bone marrow to reproduce the red blood cells that's needed. And that's often the first symptom that will lead to the diagnosis of multiple myeloma. They can also have renal insufficiency, about 20 to 25% of the patients, as light chains cast neuropathy occurs, and myeloma kidney is another name for it, as the plasma cells will clog up the renal tubules and interfere with the ability of the kidneys to filter very well. Most patients present with a creatinine greater than 2. Hypercalcemia, calcium level is often greater than 11 in about 13 to 30% of the patients. They're often present with some confusion and excessive thirst. Neuropathy at baseline can occur in about 20% of the patients, where they present with numbness, tingling. Carpal tunnel is also something to look for. And if the patient presents with that, you want to think about perhaps amyloidosis. Immune function deficiency, as the plasma cells, they're meant to produce, when they're normal, immunoglobulins and antibodies to fight infection. And while multiple myeloma occurs, the body is no longer able to produce healthy plasma cells. They're abnormal and monoclonal. They suffer from recurrent infections. The risk factors. Most of the patients, the median age is 65 to 70. It's twice as likely to occur in African Americans than Caucasians, and it's more common in men than in women. Those at higher risk have a first-degree relative with multiple myeloma, so there is a genetic component involved. Exposures. We don't know exactly what causes multiple myeloma, but clearly anyone that's been exposed to radiation or pesticides. In California, we have large pockets of farming community that we see a lot of patients referred there with multiple myeloma. Also, people that have worked in the furniture industry. Other factors to consider is obesity and any chronic immune stimulation diseases such as lupus. On diagnostic evaluation, you want to make sure that you particularly pay attention to the history of the patient when you do your physical, especially knowing what their history has been will really help to figure out how to move forward with the patient and their treatment. There are certain laboratory tests that are unique to multiple myeloma that we'll go through later. And with the bone marrow biopsy and aspirate, it's very, very important to make sure that the flow cytometry is done to look at the immunophenotyping as well as the cytogenetics that will help to stratify the patient and their risk factors, which will help also to know how aggressive the treatment needs to be or should be, as well as the FISH testing to look at the genetic mapping, translocations, and deletions of chromosomes that can occur. Plasma cell labeling index is also important if it's available in your institution, and that really just tells you how fast the cells are proliferating. and there are certain imaging tests that are necessary for myeloma. This slide shows you the risk stratification that was developed at the Mayo Clinic. It's M-SMART, that categorizes patients into either the high risk, intermediate risk, or standard risk cytogenetics. With the high risk, it also helps you to give you a prognostic indication as well as fine-tune their treatment. Patients in a high-risk group on the FISH test will often have a deletion of 17p or translocation of chromosomes 1416 or 1420. About 25% of patients fall into that category. With the standard risk, about 75% of patients that present with myeloma fall into that category, and they have hyperdiploidy as well as translocation 1114 or translocation of 614. In the intermediate risk, what a lot of people have heard about is a cytogenetic deletion 13. These are the tests that should be done at diagnosis. Of course, you're looking at the CBC, in particular, identifying if they're anemic or not. That's often the very first symptom that the patients present with. That will lead to a further workup of figuring out what's causing the anemia. It's also important to take a look at the creatinine level, looking at the metabolic panel. About 19% of the patients have an elevated creatinine level, and about 13% with hypercalcemia and a low albumin level. The LDH and the beta-2 microglobulin reflects the tumor burden that is present. And this is what we often refer to as a myeloma panel. There is an SPEP, a protein electrophoresis, that measures the amount of monoclonal present in the serum or in the urine. About less than 3%, however, don't express that, and they have non-secretory disease. Quantitative immunoglobulins, very important. About 52% of the patients, that's the most common, will have an IgG type of myeloma. The immunofixation identifies the light and heavy chain and the type of M protein present. Serum free light chain that measures a lambda light chain, kappa light chain, and gives you a ratio. Also very important with patients that were thought to be previously non-secretory, they'll actually express either a kappa or a lambda light chain. 24-hour urine is important at baseline to see if the patient will spill over any of the M protein into the urine. It's also known as Benz-Jones proteinuria. And about 20% of the patients that lack the M protein in the serum, but you can pick it up in the urine. The imaging test, there's a skeletal survey that does x-rays from head to toe that will identify the extent of bone disease that's involved. If there are osteolytic lesions, osteopenia, or osteoporosis, that's quite common with a patient with multiple myeloma. Also looking at the extent of the bone loss with the bone density, MRIs with the patient that has back pain, to identify the location and the size of any plasmacytomas that might be present, fractures, and to rule out especially spinal cord compression. We often see patients actually present with spinal cord compression, and that's an onc emergency requiring radiation immediately. A PET scan is also prudent to look at the extent of the disease, and it's helpful, especially in patients that have non-secretory disease, to help you evaluate the response to treatment. Diagnostic criteria. Let's pay attention to this. This is part of what we were asking in the beginning. There are several categories of myeloma. There's MGUS, it's a monoclonal gammopathy of undetermined significance. It's the most benign form of myeloma. There is very little M protein present, less than 3 grams. Also, the plasma cells in the bone marrow is less than 10%, and there is no end organ damage. So those patients do very well. In fact, about 1% might progress in 5 years, as well as they may not and just have MGUS throughout the continuum of their disease. The next category is smoldering multiple myeloma, or SMM. You'll see in a future slide. That has a presence of just a little bit more M protein, greater than 3 grams. It can also have more plasma cells present in the bone marrow, greater than 10%, but there is no end organ damage. And this is an area that's being looked at whether there are clinical trials, whether we should start treating the patients earlier or not. Active disease, multiple myeloma, is when you have greater than 10% plasma cells in the bone marrow, the presence of an M protein in the serum or urine, and at least one of the following, the end organ damage, the CRAB that's present. Now, with the M protein, if they're non-secretory, then obviously that they will not express that. There are also solitary plasmacytomas that can occur in the bone as well as soft tissue. And if they have just a plasmacytoma, then they will benefit from radiation, and their prognosis is quite good. The staging system, this is the newer, there are 2 staging systems. This was developed in 2005. It's the international staging system, which helps tell you the prognosis. Patients that have stage 1 disease, the median survival is 62 months, and stage 3 disease, 29 months. There are 2 areas that's a very simplified form of staging system, 2 blood tests that you look at, the beta-2 microglobulin that reflects the tumor burden, as well as the albumin level. If the beta-2 is less than 3.5 and the albumin is normal and it's greater than 3.5, they have stage 1 disease. If the beta-2 is high and it's greater than 5.5, then they have stage 3 disease, and literally anything in between is stage 2. This is a Dury-Salmon staging system, and this was developed in 1975. It's more complex, requiring a lot of different areas to factor in. What is the hemoglobin level, the calcium level, as well as extent of the bone disease, the M protein, and whether there is M protein in the serum or urine. And you have stage 1, 2, and 3. That you will still see in use, especially with a clinical trial. And now a practice pattern question. Mr. Smith is a 65-year-old patient who presents with kappa light chain. It's 125 milligrams per liter and 15% plasma cells present in the bone marrow. The creatinine is 1, the hemoglobin is 12, calcium 8.4, and there is an absence of bone lesions. The most appropriate management is to begin treatment right away, observe and follow up in 1 year, reevaluate in 3 months, consider an autologous stem cell transplant, or enroll in a clinical trial. Very good. Now, number 3 is correct, to reevaluate in 3 months, as well as number 5, to enroll in a clinical trial. And that is the current consensus with this patient, because he has a kappa light chain that's present, plasma cells that are greater than 10%, he has 15% plasma cells, the creatinine, hemoglobin, calcium levels are normal, and also there's an absence of bone lesions, so there is no end organ damage, and that puts this patient into a smoldering category. The key takeaways with this section is to know that multiple myeloma is a malignant proliferation of a single clone of the plasma cells, and it arises from the B cells in the bone marrow. Most patients present with bone pain and anemia. Cytogenetic evaluation is very important when doing a bone marrow biopsy. That will help risk stratification as well as management of the disease. The myeloma panel should be monitored closely prior to therapy and also to follow the response to therapy or whether they're relapsing. Diagnosing myeloma at an early age helps to prevent any organ damage that can occur, such as renal failure and fractures. And this is a post-assessment question. What is the diagnostic criteria for multiple myeloma? Greater than 3 grams M protein in the serum or urine, greater than 10% clonal plasma cells in the bone marrow, no end organ damage, at least one of the following: hypercalcemia, renal insufficiency, anemia, or bone disease. Very good. Thank you. And so that is correct. It's 1. There is greater than 3 grams of M protein, greater than 10% plasma cells, that's 2, and with 4, at least 1 end organ damage. Excellent. And now the next section, we'll take a look at first-line treatment options for patients with myeloma. We will begin with a case study. This is a 60-year-old man who in July 2010 presented with chest pains and dyspnea. He had a stent placed for coronary artery disease, and he was placed on an antiplatelet agent. In August, he developed hematuria and proteinuria. He was treated for UTI. By November, he had severe mid and lower back pain, and it was not caused by any trauma. He was fatigued, and he didn't feel better even though he had the stent placed. The UTI was resolved, and they ran some lab tests. His had immunofixation positive for kappa light chain. And here with his labs, he was anemic. His hemoglobin was 7.7, hematocrit 21.2. The creatinine, he had insufficiency, renal failure, 3.1 was the creatinine, and he was hypercalcemic with a calcium level of 14.3. And those are the main points on this slide. He also had related organ damage using the CRAT criteria again. You can see where the hypercalcemia was 14.3, the renal failure with the creatinine 3.1, and he was anemic. So he actually had all 4 present. You can see the calvarium. Is it this button? Where it literally punches out holes in the skull, and it tends to look like Swiss cheese. And he also had a fracture present in his femur. The bone marrow plasma cell that he had 20% present in his bone marrow. The FISH testing was not performed. Cytogenetics was 46XY. And with his staging, his albumin level was 3.6, and the beta-2 was very high. It was 6, and he had Salmon staging system, stage 3. The monoclonal proteins at diagnosis, he did not express an M spike. It was negative, so that's sort of a non-secretory type of disease, but we were able to detect the light chains, the kappa light chains in the serum, which were quite high, and it was over 3,000 milligrams per liter. The urinary M protein, he also did spill some protein in the urine, and it was 2.81 grams in a 24-hour collection. So this patient, the diagnosis was symptomatic multiple myeloma with a kappa light chain. Treatments to consider with a newly diagnosed patient: they need induction chemotherapy, and the goal of the therapy is really to choose something that's going to work quickly and to bring the disease under control and reverse any disease-related complications or organ damage, such as the renal failure and the anemia and the hypercalcemia. This patient, with this type of treatment, you can decrease the risk of early death. And also keep in mind, when you're picking the treatment, the physician picks, that we're actually looking for something that they can easily tolerate and also to manage the toxicities and not interfere with the collection of the ability to collect stem cells if this patient is a transplant candidate. Should all patients receive induction chemotherapy? You have the categories of MGUS, smoldering myeloma, and active multiple myeloma. And only patients currently with symptomatic multiple myeloma require treatment. There is a trial ongoing looking at whether we should start sooner with patients with smoldering myeloma. There is some evidence that they may benefit, but we don't have that answer as yet. And that trial looked at using lenalidomide and dexamethasone. The percentage of patients with MGUS may never require treatment. Even if they have an increased serum free light chain ratio, the higher M protein may indicate a group more likely to progress to symptomatic myeloma. But if they have an MGUS, the current consensus is to observe them and not treat. There are three key agents at the moment: bortezomib, lenalidomide, and thalidomide, that has been FDA approved to be used in combination with corticosteroids. One of the first treatment decisions to consider is whether this patient is a transplant candidate or not. What do you do? If they are transplant ineligible or choose not to have a transplant, then it's okay to use melphalan, bortezomib, lenalidomide, and thalidomide, and there are various combinations that can be used. If they are transplant eligible, what you want to make sure is that you choose a treatment that's not going to interfere with the ability to collect the stem cells and to harvest it, such as melphalan or any other alkylating type of agents. The induction therapy is required, and then they can move on to either an early transplant or a delayed type of autologous transplant. How do you treat the patient with multiple myeloma? These are some of the most common regimens. It's not all-inclusive. And these shows the drugs that we have that are currently FDA approved: bortezomib, dexamethasone combination. Cyclophosphamide could also be added, as well as lenalidomide or thalidomide. The standard dosing for bortezomib is 1.3 milligrams per meter squared. We now have an indication that can be given sub-Q or IV, and it's day 1, 4, 8, 11, so it's twice a week, and it repeats. They have an off week. And there's also dexamethasone with 20 milligrams daily that can be given days 1, the day of, and day after with the bortezomib. Lenalidomide, the standard dosing is 25 milligrams daily. It's an oral agent, and it's given for 21 days, and then it's a 28-day cycle. Dexamethasone is also used in that regimen. Bortezomib can also be added. Thalidomide, it's been around for quite a while, and the standard dosing in our practice is lower than what we have on the slide, but for most institutions it's 200 milligrams, and it's also an oral agent, and it's given days 1 through 28, and there are no breaks with thalidomide. They just take it every day. Non-transplant candidates, you can choose any of the above, as well as using some melphalan with it. There is The VISTA trial with melphalan, prednisone, and bortezomib, it was a 9 cycles, 6-week cycle. Melphalan 9 milligrams per meter squared given orally in combination with prednisone 60 milligrams per meter squared, and that was given days 1 through 4. Bortezomib was given days twice a week, days 1, 4, 8, and 11, and it was repeated for 6 weeks total. And that was also had improved the progression-free survival was the result of that trial. So it's also a very good option for any patient that is not a transplant candidate. This is a nice grid that was developed by the Mayo Clinic looking at the cytogenetics of the patient, whether they fell into a high risk, intermediate risk, or standard risk therapy group. To about 25% of the patients, again, fall into the high-risk category. 75% of the patients are standard risk. And with the high risk, you want to be more, You want to be more aggressive with their treatment. You can choose a cyborg regimen that has cytoxin, bortezomib, dexamethasone, or bortezomib with lenalidomide, and that's what the RD is. And then collect stem cells, take them to transplant, and do a maintenance type of therapy is the recommendation for the high-risk group. In the standard risk, the recommendation is to choose 4 cycles of lenalidomide instead, collect the stem cells, and take them to transplant or continue the lenalidomide as maintenance. The common side effects of the therapies with oral thalidomide and bortezomib, what they have in common is peripheral neuropathy, that they can cause peripheral neuropathy. Thrombosis is more common in patients that are on thalidomide and lenalidomide. Myelosuppression across the board with lenalidomide. Most patients will have problems with neutropenia, thrombocytopenia, and anemia. With the bortezomib, most patients tend to have thrombocytopenia occur. Hypotension can also occur with patients that are on bortezomib. Fatigue and sedation, that's still the #1 complaint across the board. A rash can occur with patients on thalidomide and lenalidomide, and the GI disturbance with bortezomib and lenalidomide, you can have diarrhea occur. With thalidomide, it's mainly constipation. Important considerations for patients with bone disease. The malignant cells is what's causing all the destruction to the bone cells. And what you want to choose is bisphosphonate, either pomidronate or zoledronic acid, that will help to inhibit the bone destruction. Monitor the patients. It can cause flu-like symptoms and chills. It can also cause renal dysfunction. So those patients, you need to make sure that you're checking your creatinine level before giving the bisphosphonate. If it's greater than 1.4, alert your physician. Osteonecrosis of the jaw, that was first identified in the dental world, that there was a problem. Patients that were on long-term bisphosphonates would develop osteonecrosis, where if they had a tooth extraction, massive infection would occur. And the current consensus is to give the bisphosphonate for 2 years, and there are trials ongoing as to whether how we need to give it, perhaps at every 3 months is what we're looking at. And if they have the osteonecrosis, of course, you need to hold the bisphosphonate. Important considerations with infections. That is the leading cause of death with patients with multiple myeloma. The IG levels with how the immune system is affected by multiple myeloma, of course, plays a role with having our patients more prone to picking up an infection. The plasma cells that infiltrate the bone marrow really suppress the ability for it to function very well. Corticosteroids, the treatments that we place the patient on post-transplant, they're at higher risk to develop infections. And the most important thing we can do is to educate the patients of the symptoms that they need to report signs of an infection. Also noting that if they have an infection, they don't necessarily have a fever. So you're looking for other subtle type of symptoms such as chills or a UTI. And consider IVIG if they have frequent infections. We also make sure that we vaccinate the patients with a pneumococcal vaccine as well as influenza vaccine each year. And if they're on bortezomib, need to make sure that you have prophylaxis on board for an antiviral, that bortezomib has been known to reactivate the herpes zoster virus. Other considerations, neuropathy. Neuropathy is damage to the peripheral nervous system that occurs, inflammation or degeneration of the peripheral nerve fibers. It can be sensory motor, or autonomic. The incidence of chemotherapy-induced peripheral neuropathy is increasing, and that's something that we can help the patients with to be the first to identify when this is occurring. So many patients they need to know what the symptoms are and to report it, and so that we can take the necessary steps to intervene and dose reduce as needed. If we're doing a really good job, then you want to maintain your patients at just a grade 2 and avoid any grade 3 or 4 complications. It can become life-threatening. Venous thromboembolic events, that having the disease itself puts them at higher risk for having a clot. They can develop DVTs or PEs, especially if they're treated with some of the novel agents such as thalidomide and lenalidomide. If they've had prior clots or surgery, if they're immobile, which often happens with our patients with fractures and cord compressions, they're not very mobile. All patients should receive an anticoagulant as a prophylactic. And DVTs can be evaluated using a duplex ultrasound or doing a spiral CT to evaluate pulmonary embolism. Some of the things that we can teach our patients is to really get them more mobile, to ambulate, consider physical therapy, stockings, side effect management, what is the risk of VTE. Again, these we have gone through, the infectious diseases, bone health, the GI symptoms, and these are some of the things that we can do to manage those side effects with peripheral neuropathy, to make sure you do your baseline assessment and follow-up assessment. The data on the bortezomib VISTA trial, there were 655 patients where they compared melphalan prednisone to melphalan prednisone. And what they found is that the median overall survival was far superior in the bortezomib melphalan prednisone arm, 56.4 months versus 43.1 months in the melphalan prednisone arm. With lenalidomide, it's similar to bortezomib, and it's a good option for frontline treatment, although we don't truly have that indication as yet. In trials, it's been known to improve the lifespan, the overall survival of the patient. It is an immunomodulatory agent. It's used in the non-transplant setting as well as the post-transplant setting in various combinations. With the patient responding to treatment, this is a very good guide that was developed by the International Myeloma Working Group that tells you when a patient has a complete remission, and what's really the newest category is a stringent complete response that factors in the free light chain ratio, and if that's negative, then they have a stringent complete response. And with our case study, going back to that, this patient did not want an upfront transplant. The induction regimen that was used, they opted for a clinical trial, included bortezomib, dexamethasone, and cyclophosphamide. That's a cyborg regimen. The patient developed peripheral neuropathy and opted to withdraw from the trial because of the neuropathy. He had heard in some support groups about the sub-Q indication that was being used. With the sub-Q indication, those patients had less problems with neuropathy. So after 8 cycles, he did improve, as well as his neuropathy. He responded to treatment, and he switched from cyclophosphamide to lenalidomide to deepen the depth of the response. And the patient achieved a complete remission and remains sustained, which remains sustained. So the case study question, you're the nurse caring for this patient. Remember his lab results. He was anemic, had renal insufficiency, hypercalcemia, and lesions in his bone, and he started on cycle 1 of treatment. So what is the most important supportive care therapy that you would consider? Using GCSF, growth factors, platelet transfusions, bone marrow transplant, bisphosphonates, acyclovir, or none of the above? That's good. Bisphosphonates and acyclovir. The key takeaway is that there is really not a gold standard treatment for myeloma. We have so many options now. It's been a very exciting time with all the newer agents, and nurses play the most important role in managing the side effects so we can keep the patient on therapy for as long as possible. This is really a chronic, incurable disease, and the newer dosing strategies is to decrease the doses of the drugs that we're using to manage the side effects. Thank you so much.
Thank you, Paige, for that wonderful review. I wanted to talk with you about maintenance therapy. Keith, you could see him flapping his arms in the audience. If you have any questions, we're going to try to be succinct so we can answer all of them. Which maintenance therapy, this is a pre-question, have demonstrated improved progression-free survival? Bortezomib, thalidomide, carfilzomib, lenalidomide, and you can read the rest. Okay, and remember you get the question at the end. So let's start with a maintenance case study. Mr. P is a 48-year-old with newly diagnosed IgG-kappa multiple myeloma. About 73% of your patients will have that type of myeloma. His M spike was high, 5.2. Remember, Paige said you shouldn't have this in the blood or the urine, but he had a high level. And that CRAB, you were all very proficient in identifying what CRAB was. He had renal insufficiency, creatinine 2.8. He had anemia 8.8. And a lot of times those go together at diagnosis. He had 4 cycles of induction chemotherapy. Like Paige said, we're inducing a response and getting him into a remission. He received bortezomib and dexamethasone and an autologous stem cell transplant. Would he be a candidate for maintenance therapy? So maintenance therapy is the use of ongoing, low-intensity medication to keep the response. Myeloma has been turned into a chronic disease. Think of your patients with diabetes. If we stop the anti-diabetic drugs, the disease will come back. And it's the same with myeloma. The overall survival is about 5 years, but I'll tell you, we have patients 10, 15, 20 years out. So how do we maintain that response? And this is where the field of myeloma is going. It's administered when the disease is in remission, and the purpose is to keep things quiet. We have 2 key drugs classes to treat myeloma. The immunomodulatory drugs, those are the pills, lenalidomide and thalidomide, and the proteasome inhibitors, which is bortezomib. I'm not going to go into detail on this slide. This is just all the studies that use thalidomide pills as maintenance. Unfortunately, patients develop peripheral neuropathy that had a lesser quality of life. So it's something we don't use as much because we have newer drugs with less side effects. Although it did show that patients stayed in remission longer, there was no improved survival. Lenalidomide, a second-generation oral pill. Paige had mentioned about it. Myelosuppression may be the biggest side effect from it. This study used patients who got transplant with melphalan, 200 milligrams per meter squared. Then they had maintenance or no maintenance, which was placebo. And in this study, you can see the curve over here. The overall survival was increased in the patients that got the lenalidomide after transplant. So this one study did show that it was an improved survival. Another study by the French myeloma group, the IFM, looked at the same thing. Anybody got whatever kind of treatment, then transplant, and then were randomized to consolidation and maintenance. The consolidation was 2 months of a higher dose of lenalidomide, and then the same dose of maintenance, 10 to 15 milligrams is tolerated. And what this showed as well is the patients did better when they had the maintenance than when they had the placebo over here. So again, these studies show that lenalidomide after transplant can keep patients in remission longer. Well, what about the people that can't have transplant? Transplant is an option, but it's not an option for everybody. Reasons why people would receive a transplant would be if they're younger age, if they have more aggressive disease, but not too aggressive, because we want to control the disease, and basically desire, financial status. These are all reasons why transplant would occur. We don't need to do an upfront transplant. We can do it at any time during the disease. We just tend to get more remission duration out of an earlier transplant. At any rate, if your patient's not a transplant candidate, the Italian myeloma group with Dr. Palumbo used melphalan and prednisone pills with lenalidomide pills, or melphalan, prednisone, lenalidomide with lenalidomide maintenance, or just plain melphalan and prednisone. And what we saw in this study is that the group that had the melphalan, prednisone, and lenalidomide with the maintenance did much better than the patients who did not have the maintenance. Now, what about bortezomib? We talked about our immunomodulatory drugs, thalidomide and lenalidomide. Now let's talk about bortezomib. Bortezomib is a proteasome inhibitor. It's now FDA approved for shot, subcutaneous use, as well as IV. In this HOVON trial, what we saw was 2 different kinds of induction, one with the bortezomib, adriamycin, and dexamethasone, and then the other had bortezomib, doxorubicin, dexamethasone, and they had transplant. And basically, the take-home point, and I know we all love these curves. I'm sorry that they're up here. The take-home point on this slide is that the overall survival was increased. Look at this over here. The patients that had the 3-year overall survival that had that had the bortezomib before and after, it really improved the transplant outcomes after transplant. So in conclusion, there's many different ways of doing maintenance. You don't need to do maintenance, but we have many studies that say giving treatment after they're in remission will keep you in remission longer. Now our case study, Mr. P, 3 months after transplant, he had a partial response. And Paige showed us that graph that says, okay, when they're getting into remission, how deep is the remission? We want to get rid of as much protein as possible. He had an 80% reduction in the serum M protein, which he had a little more room to go down. His M spike was 0.49. So he gave the high-dose chemotherapy, but it didn't knock it out. But his renal insufficiency and anemia resolved. Look at his normal creatinine and hemoglobin levels. He had anemia and elevated creatinine diagnosis. And the question is, would he be a good candidate for maintenance? And the answer is yes. We didn't get rid of all the protein. He's a young, healthy guy right now. Let's go ahead and deepen the response as best as possible. So he began maintenance with lenalidomide pills, 10 milligrams daily, like in one of our transplant trials. So maintenance therapy will delay the recurrence of myeloma and prolong the progression-free survival, or the time you're in remission. One of the questions that we received before registering for the program, which I wanted to address, was the role of single and tandem transplant. Now, Mr. P had not gotten rid of all the protein, and he might have been one of the patients that when you look at all the transplant trials, he could have actually had a second transplant at that time and then gone to maintenance. So again, it's different institutions, very physician-specific, but now we have these new great drugs that are very active. So why put him through that second transplant when we can give a pill and keep him on that pill to hopefully do the same, meet the same endpoint? We know bortezomib and lenalidomide are probably better than thalidomide, based on the earlier curves, for high-risk disease. But the take-home point is that most people should be on something. And we have newer emerging studies that are ongoing. So here's your post-assessment question. Which maintenance therapies have demonstrated improved progression-free survival? Bortezomib, thalidomide, carfilzomib, lenalidomide. None of the above. Let's see. I know I like, all right, I can't tell you which one I like. Number 6, 1, 2, 4, 1 and 4 only. And then you can see the last one, 2 and 4. Yay! Good job. Congratulations. Congratulations. I'm trying to rile you up this morning, get you ready for a good day at Congress, right? So here's your pre-assessment question. We're talking about relapse patients. The following agents are or have been investigated in phase 3 trials for relapsed myeloma: pomalidomide, carfilzomib, vorinostat, panobinostat, MLN 9708, and you can read the rest of the ones, all of the above or whatever combination. Okay, so we're going to go back to Mr. P. I like him a lot, so I'm going to carry that case study through this. So he stayed on lenalidomide, 10 milligrams daily for 3 years. He had a good long remission. Unfortunately, he developed lower back pain and worsening anemia. A bone survey, these are the x-rays from head to toe, developed an L2 vertebral compression fracture and calvarial skull lesions consistent with disease progression. And Pat and I were just talking a few moments ago. X-rays are not very sensitive to detect lesions. You need 30 to 40% bone loss before an X-ray will find it. So while you have a compression fracture, those are the vertebrae, the building blocks of the spine, it'll oftentimes pick it up. But if you're having early bone changes, CAT scans and MRIs might be more sensitive. So if I would have X-rayed him and found nothing, but he still had symptoms, I would proceed with a CAT scan or an MRI, which might be a little bit more sensitive. At any rate, these are his labs listed on the screen here. His M spike was 0.95. So remember, he started at 5 point something. So it's still pretty low, but he'd gotten rid of all his protein, so now it's coming back. The repeat was in March 1.32 grams per deciliter, so that it was an increase of 25%. He had the anemia. The creatinine's bumping up again. Remember, he started in renal failure. These are things we're going to look at relapse. And so he has relapsed myeloma. And what are his treatment options? Well, first let's define relapse. Relapse is defined as reappearance of the abnormal protein or signs of symptoms of the disease. So he had a transplant, he was in a nice remission, and now he's having signs of the disease, his protein came back. Here listed on the 1 through 6, and you can read these as well, development of soft tissue plasmacytomas. That's a clump of tumor or plasma cells that can affix to bone, which is called osseous, or it can be floating around anywhere. I've had plasmacytomas in some of my patients in their belly or in their arms, but it tends to affix to bone because it arises from the bone. Hypercalcemia, anemia, those are your crab symptoms that come back. And here it's illustrated for you. When you have a symptomatic relapse, you have that crab. So our goal here is to try to get to Mr. P before he gets that crab. Delay the worsening of bone damage. One of the things we look at is doubling of paraprotein. Other diseases like chronic leukemia or CLL, when you're seeing a doubling of the white count, you say, okay, maybe it's time to start treatment. That might be a treatment trigger. Well, doubling of paraprotein is also something we look for. Some people will have the asymptomatic biochemical relapse, and that should not be treated or retreated until we get signs of the disease. And nurses are critical. You're the ones that are checking for when you're on the Iridia or the zoledronic acid every month. You're checking the creatinine, and you're looking, and if you're changing the dose of the zoledronic acid because the creatinine changes, then this needs to be, the practitioner needs to be notified. Now, refractory means that the proteins come back and that they're not responding. Within 60 days is usually the take-home point of discontinuing the treatment. So when patients have protein come back, or they're having back pain or anemia or any of that crap, we want to look at these three different things. First of all, it can be disease related. Sometimes it's just the proteins coming back and we can watch and wait, but we want to make sure that it's not causing any problems. The extramedullary disease refers to this plasmacytomas that can go out of the bone. Rarely it can go into the central nervous system. Sometimes you have genetic changes as well. Patient related. What happens? Our average age of diagnosis is 70 years old. You put a patient in remission for 5 years, now they're 75, and we didn't have a survivorship care plan. We weren't doing their health maintenance, watching for COPD, telling them to stop smoking, surveillance for high blood pressure and diabetes. So other comorbidities can also occur. If they had renal insufficiency at diagnosis, it can worsen if they have diabetes. So these are all the things as nurses to be thinking about when you're caring for even one of patients. And then, of course, when your patients relapse, we think of treatment-related. Paige's patient had some neuropathy from the bortezomib. He was switched to subcutaneous, which we know the neuropathy can go from 53% to 38% was the incidence in the IV versus the subcutaneous group. So we know that it can help the neuropathy, but that might pose a challenge if we needed to give him bortezomib down the road. So here we go back to our three key novel agents, thalidomide, bortezomib, and lenalidomide. And those are the three agents that we use at diagnosis. Those are the three agents we use at relapse. And outside of a clinical trial, that's the best we have in combination. And we do combine these with existing older agents, dexamethasone, prednisone, cyclophosphamide, so we can mix and match. But by and far, clinical trials are something we should definitely recommend. I also mentioned to you before what the difference between relapse and refractory is. So let's say you're a patient like Mr. P, who's just having protein come back. And it's a slow level. He's on lenalidomide. We might want to consider something such as this bortezomib-based salvage. So maybe switch him to a bortezomib regimen, because he didn't have that for a long, long time. He was on lenalidomide maintenance. Maybe he would be a candidate for thalidomide-based salvage. So this is something that is very practice-dependent. If he's aggressively relapsing, lots of high calcium, lots of renal failure, you might want to be more aggressive and combine drugs and consider, if you still had stem cells, maybe a second transplant would be in his best interest. Look at this slide carefully, group, because this question came before. Agents in phase 3 studies. Phase 3 studies mean we're combining the different drugs that are currently standard of care against newer ways of treating the myeloma or any disease. So we've already moved it from phase 1 is just the maximum tolerated dose. Phase 2 is let's see if it has activity in myeloma. Phase 3 is okay, we know it works in myeloma, we've got the great dose, let's see if it's better than the standard of care. So what we see here is pomalidomide in combination with dexamethasone is a new form of Revlimid or lenalidomide. Carfilzomib is a new proteasome inhibitor. These are the two hot drugs that are currently waiting for FDA approval. They were just submitted, lenalidomide recently this week, and carfilzomib we're going to hear pending in June or July of this year, to my understanding. Verinostat, panobinostat, elotuzumab, and perifosine. So in terms of the molecular structure of thalidomide, pomalidomide, there will be a test. I'm going to get a blackboard and you'll all have to draw these chemical structures. The take-home point is they're chemically similar, but they are different side effects. And Paige shared with you the side effects. Lenalidomide and pomalidomide cause more myelosuppression than thalidomide, which causes neuropathy and fatigue. Pomalidomide is a hot new drug that you're going to be hearing a lot about. It was shown to be effective by itself and in combination with dexamethasone. Dexamethasone poisons IL-6. IL-6 is a growth factor for myeloma cells. Without it, they can't survive. So steroids of any kind you'll see are with all of our myeloma regimens, similar to like the lymphoma regimens have prednisone. At any rate, it tends to help the disease control, and here we see here that the duration of response was very similar in both groups, 8.5 in pomalidomide and 7.9 with dexamethasone. But again, we're only looking at the responders, so that's why it's a little bit different. But the take-home point is that it can put patients in remission longer. Carfilzomib, a new proteasome inhibitor, new form of bortezomib. It's an IV. It's given twice weekly on a 21-day schedule. And what we're looking for is, we don't have a good overall survival, but so far we have these are not updated data, but the median overall survival about 15.5 months. So that tells us that as a single agent, again, it could put patients into remission. This is a bortezomib and vorinostat study. Bortezomib, again, is FDA approved, and we're studying it with combination of vorinostat, which is FDA approved for different forms of lymphoma. And we can see that it did make little gains, bortezomib versus bortezomib placebo. So again, in combination, vorinostat might give you a second option. Again, a lot of these patients were living longer for these newer drugs, and we're still finding great ways of using them. Another one I'm very excited about is elotuzumab with lenalidomide and weekly dexamethasone. We have, remember, bortezomib, lenalidomide, and thalidomide. These are our gold standard FDA approved. Now we're using elotuzumab, which is a monoclonal antibody. The lymphoma patients have rituximab now. Hopefully we'll have elotuzumab. And in combination, we're seeing that it's having a good response as well. Perifosine and bortezomib is, again, something that has activity in myeloma. We have what's called a clinical benefit response. Patients are getting a benefit from it. We might not have our home run, but perifosine is a very good treatment in combination with bortezomib and dexamethasone. So Mr. P is enrolled in a clinical trial with lenalidomide, elotuzumab, and dexamethasone. He was on the bortezomib. We can go back to that later on. That's what he had before transplant. So we know it's going to work for him, so why not go back to it later on? So there's just no gold standard of what to do, and this was available at his center. He had a very good partial response. 90% of the abnormal protein went away within the first 3 months of therapy. He had some side effects of myelosuppression, which were very, very mild. That's the neutropenia and anemia, and he continues on therapy and in remission. The key takeaways are that the overall survival has increased with myeloma. We are so excited to have these different options available, and to think pomalidomide and carfilzomib can be at our hands in the next year or so is a very wonderful thing for our patients. The diagnosis has transitioned to a chronic disease, so nurses should be aware of that. So when you see a patient in the hospital admitted for back pain, know that oftentimes we have options available. Here's your post-assessment question. The following agents are or have been investigated in phase 3 trials for relapsed myeloma: pomalidomide, carfilzomib, vorinostat, panobinostat, MLN 9708, all of the above, 2, 3, and 4, or 1, 2, 3, 4. 1, 2, 3, and 4. Was that the right answer? Yeah, I think it's 1, 2, 3, or 4. Sorry, I fell asleep for a minute. All right, I'm going to introduce Pat Killingsworth. He's a columnist for the Myeloma Beacon, and he runs a blog, and he's going to tell you all about from the patient perspective. Pat, please come up here. Thank you. Just forwards it if you have anything.
Do I have anything?
There you go.
Oncology nurses rock! I'm the entertainment to close out the program. 5 years. I was diagnosed in 2007. In a lot of ways, I am a truly typical patient, and in some ways I'm not. I guess I was young. I was diagnosed at 51, so that makes me young in the myeloma world. And probably one reason that doctors weren't looking for it, nurses weren't looking for it. We talked about someone exhibiting lower back pain when they come in, and something to keep in mind, but I guess I was just a little too young, so really nobody looked. By the time they figured out I had myeloma, we used the term Swiss cheese before. Oh my God, I mean, and that's interesting. The x-rays showed almost nothing. Just a little, I was a mess. I was all Vicodined up at the time because I had a little stress fracture. I'd sneezed in the shower, and I fractured my T12. And I couldn't, I couldn't move. And I was in bed for weeks. And just a little crack maybe that somebody could see, could isolate. And then they did an MRI. Oh my God. I mean, and the radiation oncologist showed me slice by slice, page by page, and I just sat there literally, well, it was sort of like a fascinated horror as I saw 2 inches of missing rib here. Just oozing myeloma lesions squeezing out between my vertebrae. Missing 2/3 of my T12 was gone. A third of another vertebrae was gone. My hip, I had a 2 or 3 inch lesion in my hip. And I just sat and watched this slice by slice. So really, an MRI, if it hadn't been for the MRI, we wouldn't have known I had myeloma because all my counts were great. My calcium was great. My IgG, nothing was really bad. And they did, so I'm a typical IgG kappa, and so M spike works for me. And I had a high M spike, and they finally figured out what was going on. And they put me on lenalidomide. I always want to say Revlimid. And it worked so well. Now, this is back in 2007. I was in western Wisconsin, so I was fortunate that it was 2 hours away. Mayo Clinic was one of my primary sources through insurance. So I was able to go to Mayo, so I had really great care. So I went through 3 or 4 days of testing and poking and prodding, and I don't know how I did it. I was not feeling well, but I went through the process, and so there I am sitting with the doctor and with the hematologist, with the specialist, and he's talking about my myeloma, and he said, well, Pat, the average myeloma patient who faced with, I guess I was in stage 2, lives 43 months. Now, what we'll do is we'll get your counts down as low as we can, and then you'll get a stem cell transplant. Well, I had no idea what a stem cell transplant was. When they told me I had multiple myeloma, I didn't even know it was cancer. You're in a fog, you're in a daze. Stem cell transplant, and then you go on the internet. I don't want to go through one of those, A second stem cell transplant? No, that's not a great idea. Well, so I go on RevDex, and it works great. Everything's going great. And so when I went back for follow-up to see the doctor, I said, well, can't I wait? Because my M spike was now a 0.4, I think. Revlimid had brought me from a 3.8 or 3.6 or something down to a 0.4 in 3 months. You ready to transplant? Well, do I have to? Revlimid's working. Why do I have to transplant? Well, Pat, I suppose. Think of it like a Band-Aid. Are you going to pull the Band-Aid back slowly, or are you going to rip it off? I think the rip it off was the transplant. And it was rare back then, but he was supportive. I decided to wait. And 6 months later, I was in a complete response. And I maintained a CR for 3 years. No transplant, just Revlimid. It was great. Then after, it's now close to 4 years, my myeloma became active again. And I got to a 0.5 or 0.6, which is almost nothing. But I already had lesions showing up. So this time we ran a PET scan. An MRI was able to identify a new inch of plasmacytoma in my hip. Myeloma loves my right hip. I don't know what is going on, but it always shows up there. And then I did a PET scan, and I lit up like a Christmas tree. And this was with an M spike of like 0.5. So watching and waiting for me was not going to be an option after I relapsed. I had spots on both iliac crests, my cervical spine, my head, my hip. It was time to do something. And although I've waited almost 4 or 5 years, I decided to transplant, to get an auto transplant. And I had harvested at Mayo 4 years before. And I had now moved to Florida. I live north of Tampa. We'd lived there about 3 years. So I was going to Moffitt Cancer Center. And so they brought my stem cells down on ice. And we did an auto transplant in July, which I actually tolerated it quite well. I don't want to do another one, thank you. But I'm relatively young and strong, all the platitudes. And yeah, I suppose it was tolerable. I mean, I was pretty sick for several weeks, and it took me 2 or 3 months to start feeling normal and get my energy back again. But it wasn't. I would do it again if I thought I had it was going to help. Didn't help though. It basically pissed the myeloma off. I went in with almost no M spike at all. I'd had a bone marrow biopsy, and it was clean. 1% plasma cells, no myeloma cells. I come out after 3 months. I'm at a 0.5, and I've got plasma cells in my bone marrow again. We'll test again. So 2 weeks later, it's 0.6. Well, that really got everybody's attention. The unusual thing about me as a patient, although going through all of this is quite normal, and the fact that I was a bit younger when I was diagnosed, is that I'm probably the classic informed patient. So I write for the Myeloma Beacon. I have a daily blog, multiple myeloma blog. I operate myelomanews.com, and I've written several books about it. I thought, well, I'll write a little 100-page book about my stem cell transplant process. Well, it's 344 pages, but who's counting? That's right. They do inpatient at Moffitt, which is unusual. So I'm there following donor patients around, allo stem cell patients, holding on to my IV pole, as we walk down the hall, and I'm interviewing these people, and it was really fascinating. So I ended up with a book with tips from 40 or 50 patients who shared what they would have done differently if they could, what they might do later, and that kind of thing. I think the important thing for you as nurses is to think about the frame of mind that a patient is in when you're talking to them or when you're working with them. So the first month or two, even if you're not sick like I was, and I was, hey, do not combine heavy radiation with daily dexamethasone. It's not a good idea. I mean, I was a wreck. I couldn't sleep. I couldn't stand. It was just a horrible type of vertigo, nausea. I was not doing great. I didn't have time to focus on choices, on learning about what my therapy choices would be. But even if you're okay, even if you're asymptomatic, somebody has just told you of cancer. Someone has just told you of an incurable cancer. And even now, if you don't have a lot of the high risk factors, and your doctor says you could live a decade, the doctor's excited. You could live a decade. Well, the patient doesn't know that 4 or 5 years ago they were telling people it was 43 months. A decade, the patient's hearing, I'm going to die in 10 years. The physician's excited about how quickly things are progressing and how much longer his patients are living. The physician, and maybe you as nurses, you have a perspective. The patient doesn't have a perspective yet. So if you can help educate that patient with time and talk to them about the different treatment options and help them create a healthcare team and realize you need a myeloma specialist. And if you're not right there in a city like Little Rock or Rochester, Minnesota, or near a place like, or Cleveland, yes, okay, Cleveland Clinic, if you don't live in Cleveland, you're probably going to deal or work with a medical oncologist who's going to be dispensing the Revlimid or making sure that you get your IV or sub-Q Velcade. It's just important to help that patient work through all this. I mean, it's not fair to get cancer. But it's even less fair for me to have to know more about my cancer than my oncologist. But when you look at all of the options, all of the treatment options, that's basically what an informed patient needs to do. He or she needs to become an expert in multiple myeloma. So, ignore median life expectancy numbers. The median life expectancy numbers they give you right now is everybody rolled in together. I mean, wouldn't it be better? So I was diagnosed when I was 51, and I had no genetic complications, so I was a good candidate for treatment. Wouldn't it be nice if you could say life expectancy for patients between 50 and 55, low or normal risk? Now maybe there's some value to it, but to throw everybody in together when the average patient is in their 70s, 70% of myeloma patients are in their 70s. So I think we have to be careful when we use these median life expectancy numbers. Not that that's fine that my original hematologist was so frank with me. But you get into this situation where I call them myeloma years, like, dog years or cat years. I have people tell me, I've now written 3 books about myeloma. I'm working on my 4th. I'm working on a financial aid book. It's amazing the financial aid there is out there for myeloma patients. It's like the perfect storm. Leukemia, lymphoma, some of those patients are living too long. But myeloma, it's perfect. Enough patients are dying that there's money available. And I have a friend that has had myeloma for 3 years, and he's never paid a dime for his care, using grants and putting together all this. So I thought that was an important book. So that's the one I'm just finishing up now. But people say, you got these blogs, you got these books. I travel around and speak to support groups. If any of you are involved with a support group, Millennium is so wonderful, and they will pay for me to come and speak to your support group and tell my story in a more organized fashion than I have today, 10 minutes. And my 10 minutes are probably up. So, you might keep something like that in mind. Email me, pat@helpwithcancer.org. But I'm in a hurry. These are dog years. I mean, even if things go well, after my transplant, fortunately, my RVD, or Millennium is the sponsor today, so my VRD, Velcade, Revlimid, and dexamethasone, worked better than it did in the induction phase to get me ready. And I'm now, I think I'm 0.1. I'm stable. RVD's no fun after a transplant. It's hard on your body. But everything's good. I feel pretty good today. Today's a good day, even though we got up early. So I don't know. But, you just do the best you can. And all I want to end with is to thank all of you. When I come back in another life, I'm going to be an oncology nurse. So I really appreciate it, and thank you very much.
Good job. Thank you. We have about 2 minutes. We have some webcast viewers. If you have any questions, Keith is flapping his arms in the audience. First one. Thank you for the webcast viewer. How long does the patient have to take maintenance therapy for multiple myeloma? Well, that's very much under debate. The International Myeloma Working Group just put forth guidelines. This is a group of about 200 physicians that sit in a room and decide what to do with myeloma. And the recommendations are until relapse for most people. Bortezomib is 2 years, or until progressive disease or relapse. Thalidomide is if they're tolerated. I have patients on thalidomide for about 8-9 years now, and they don't have neuropathy. That's very rare, but each of these agents should be considered, and it's really until toxicity or unacceptable progressive disease. Paige has another question about smoldering myeloma. Yeah, come on up here.
Okay. The question is, what is the average length of time with symptomatic smoldering multiple myeloma? And it's 73% will progress in 15 years, patients that have smoldering multiple myeloma.
And I think that that's an important talk. We didn't talk a lot about the study with lenalidomide and dexamethasone versus placebo in smoldering myeloma. There was a study that showed that it delayed progression. We shouldn't recommend it outside of a clinical trial, but these patients with the high protein but no CRAB will progress 73% of the time at 15 years. So we're really trying to prevent organ damage. Another webcast, what percent of myeloma patients are non-secretory? Well, about 93% will have an intact immunoglobulin, like an IgG kappa, like PAT, in their blood or their urine. The free light chain is a lot lower. It ranges, if you look at the Mayo Clinic data, around 5 to 7% actually. So it is a higher percentage, and that's why it's hard to find for some. Are there any more questions? We have 3 seconds left. Thank you so much for your participation this morning. I hope you enjoyed our symposium. Don't forget to turn out your assessments on the way out and sign your form so you can get credit for coming. Thank you.